nafasi tukumbukane, nitalipa boda boda, achana mwendo kasi usijibane bane. Elo binti maringo, sijui wanisikia, pendo lako nicheze bingo, wenda nikajishindia. Mwenzako bado niko single, pendo limenichachia. Uwezuka niwe tingo, iwe abiria. Nafsi unainyong'onyeza, na isi la moyo shambulio, nifanye chipsi chombeza, japo nionja mwenzio, penzi linanilegeza. Sonona sononeti, inotapata nafasi. Sonona sonona yoyo, nambie basi. Sonona sinyonge, naishi kwa wasiwasi. Sonona beba wangu moyo, mwepesi kakaratasi. Sonona sonona. Mwaga wino wakalamu ya penzi langu, shimo shimo unizike kabla ya siku yangu. Hakuna sejua matatizo ya moyo ukipenda, unanifanya mwana sesere kuniti.
So let's do this. Hi everyone. So I want to take maybe this opportunity, guys, to welcome you to the studio. But first of all, before I do that, I want to introduce the topic of conversation tonight. Yeah, so tonight we are having a conversation about the role of technology and support. I'm sorry, guys, since there's some noise, let me try to mute your mics. All right, I'm sorry, let me try. Okay. Yes, so I want to welcome everyone for tonight's discussion. So tonight we have a conversation about the role of technology to enhance and support medical practitioners' knowledge and skills. So joining this discussion, our panelist is Dr. O.Yonga. So Dr. O.Yonga is an infectious disease specialist. We also have Dr. Mboya. So Dr. Mboya is also an Anaesthesia and also a critical care doctor. And also we have Dr. Lununi Conrad, who is an obstetrician and gynecologist resident. And also she's also the convener of KMA Young Doctors Network. So before we go to the main discussion of tonight, I want to welcome you guys to introduce yourselves, and then we'll go to the conversation. All right, so I can start with Kenta. Kenta, can you unmute your mic?
Hi. John. So nice to meet you. My name is Kenta Hala. I'm the general manager of the Africa Scam. So we will really appreciate to participate this meeting to discuss about the role of the technologies for managing and encourage of the doctors. Thank you.
All right, thank you very much. So also want maybe Dr. Yonga to introduce himself.
Yeah, thanks very much. My name is Dr. O.Yonga. I'm an infectious disease specialist, and I'm also a clinical epidemiologist. I currently chair the Division of Infectious Disease at the Fountain Healthcare Hospital in Eldoret, but I'm also a consultant in infectious disease at a number of hospitals here in Nairobi, and I'm glad to be with you.
All right, thank you very much, Dr. So I'll also now bring Dr. Mboya. Dr. Mboya, you can introduce yourself.
Okay, good evening, everyone. I'm Dr. Mboya. I'm a resident in anesthesia and clinical anesthesia and critical care based at the Kenyatta National Hospital. I'm glad to be part of the today.
All right, thank you, Dr. So now I will go to Dr. Lindsay. Dr. Lindsay, you can introduce yourself.
Hello, good evening, everybody. Thank you so much for joining us. My name is Dr. Ida Wanjiku, aka Dr. Lindsay. I am an obstetrician gynecologist resident, and I am also the co-convener of the Kenya Medical Association Young Doctors Network. I am also the co-convener of the National Kenya Medical Association of Social Welfare and Responsibility Committee. Thank you so much for having me.
Amazing. Thank you very much, Dr. So thank you guys for your introductions. Maybe you don't have to mute your mics because we don't have an issue with echoes. When I realize there is an issue with the echo, I'll mute the mic where the echo is coming from. So I'll want to start this conversation. Maybe we can now start with thinking about the situation of COVID-19 in the country, especially in terms of management and how the measures, now that we are learning that the government is extending the cessation and also curfews and also blocking the borders of Somalia and Tanzania. Maybe this question will first go to Dr. O.Yonga to tell us maybe what he thinks these measures can do.
Yeah, so apparently a number of the infections that we were seeing, in fact, I think for the last maybe 5 to 7 days, a lot of the new infections that we were seeing were more of imported infections, and they were coming from mostly two borders. That was Niger, that is literally the border between Kenya and Somalia, a bit of Mandera. I think in here we call it the Wild Wild West, because it was literally the northern frontier. And then we are also seeing a number of infection coming through Isebania as well as Migori, which is the border between Kenya and Tanzania. I know that now the president has said that there should be no movements between the three borders. But for a number of you who may be there, you might actually know that those are very porous borders. And so it may need quite a bit of vigilance and a lot of surveillance in order to prevent people from literally crossing through some of those borders. But as things stand, we are still not very sure the stability of the infections in-house. But I think the border points were really causing a lot of concern with regard to importation of infections. So I think the closure of those borders is a very good move. And I think over the next week or two, we should be able to see what transpires.
All right, interesting. Yeah, so maybe also you like to know, Mboya, what you think about this?
Okay, I think I'd like to agree, Dr. O.Yonga. Closing the borders might make us see a difference in the number of infections we have in locally, but still, from what we've seen, even as healthcare professionals who tend to go into areas where these patients are being managed, I still feel it's not really clear how many cases we have in the community, and if we are really targeting and reaching out all those patients we feel could be having COVID disease amongst us. Like, let's say the case of Isili, once we managed to close down Isili, the past 1 week, I don't know how many cases have really come out of Isili that we can say the government's mitigation or closing down those areas has made a difference. So we, as Dr. O.Yonga says, let's take some time, we'll get to see if that's gonna create any difference in the number of infections you're having locally. But I believe it's been weeks, but in Kenya, I think we are still swimming blindly. We are not really sure how many cases we have and what we are really dealing with. But generally, I feel we've not had the number of cases that turn positive, I don't think they've really been critical cases which have made the healthcare system really struggle so far. That's all I can say for me. Yeah.
Wow. Yeah. Okay. Great. So Dr. Lindsay, what do you make of these measures, and especially now, how can we manage maybe maybe contributing to what Dr. Yonga was saying?
I think the government is trying the best it can, because I think I've come to realize there's something that is very apparent about Kenyans that I actually didn't know before. We are ungovernable. We don't follow instructions. We are hard-headed. Because in my opinion, I don't think we would have needed to close borders and to, to put the barricades between counties if we just stayed at home, work from home, wash your hands, avoid social distancing, do social distancing, avoid close contact. So I think the government is helping you help yourself. So yeah, so for me, I support them because they're really trying to contain something that you as an individual should actually be doing for yourself. So the government is saving you from yourself. That's what I can say.
All right, interesting. That's interesting. So, Kenta, in terms of, you are in Japan right now, maybe in terms of Japan, comparing the measures being done in Japan and Kenya, what's Japan is doing better than what we are doing right back home?
Okay, so Japanese government, the Tokyo. So I live in the Tokyo. So Tokyo is still the locking down the little bit. So we continue to stay at home. So, but the government is not so serious. Give us to the serious lockdown, so we can go to the shopping. We can go to the exercise. Go to the exercise. But so the Japanese case is a little bit the decreasing of the number of the cases now. So the county is the finish to the locking down. So so our life a little bit closing to the normal life a little bit, but still under the control. Yeah.
All right. Interesting. So, Dr. Yonga, I want you to get the last word on this. Of course, we have been having this conversation even with you. But do you think now, of course, you have also been reiterating that actually these are the kind of measures that will help us suppress this disease. Do you think now going forward, this was actually the right way, maybe to extend even the curfew and the session? Sorry, Dr. Yonga, let me unmute you. All right.
Yeah, I was actually saying with regards to extension of the curfew, I still, when you're extending, initially when the curfews were being implemented, I think the main reason was to try and figure out how to force Kenyans to undergo some form of physical distancing. And then this was some sort of time the government was to buy to try and see if we can upscale our testing mechanisms. I think over time they've tried to do what they can. Of course, now because of market forces globally, due to the quotas that have been placed on the procurement of reagents and the Q-tip swabs, I think the government has tried all it can. Unfortunately, I think even with the institution of curfews, probably it will minimize movements at night, but during the morning rush hour and really the daytime movements have still remain unhindered. And so with regards to transmission, I personally think we'll still be dancing around the 20s, the numbers between the 20 to 30s with regards to new infections. So basically, in regard, and then also with regards to the inertia and the mistrust that a number of the members of the public have towards the public healthcare workers who are coming out to screen them. I think until we really make these people, we really increase their confidence in coming out to test, I still see some form of community transmission going on, particularly in some of the hotspot areas that have been highlighted in Nairobi.
All right, interesting. Yeah, so anyway, we want maybe to move this discussion now to the main topic of tonight. So I will start first, maybe to go to maybe this also maybe before even I go to that conversation, I want to introduce Alphonce Wera. So Alphonce Wera, you can do a quick introduction about yourself. Also, you are joining this conversation tonight. Yeah.
Okay, thank you. My name is Alphonce Were. I'm not a medical practitioner in any way, but I'm a labor policy consultant, and doctors are part of workers, and other health practitioners as well are workers. So I have an interest because of that, and the whole situation we are discussing affects work and workers in one way or the other.
Right. Amazing. Good. Thank you. So maybe I will start with Dr. Maybe let me start with Dr. Lindsay. So Dr. Lindsay, maybe can you briefly share with us the status of, especially when we are looking at technology and what technology is doing to medical practitioners in enhancing skills in what you practice, you as maybe as an obstetrician, gynecologist, how is technology enhancing your skills? Now that we understand it's medicine changes every day.
Right, so thank you for that question. So you've asked how has technology enhanced practice in medicine, and especially in the Department of Obstetrics and Gynecology. So medical technology is amazing because we have something we call fetoscopes. We have CTGs that we can actually check the fetal heart rate, deceleration and acceleration. We have MRI scans. You know, all this is technology, you know. So, I mean, it has come to make work easier for us in terms of diagnosis and, you know, and management of, you know, to enhance management of and treatment of patients. So in that regard, of course, technology is amazing. In terms of technology and other, you know, and how we get information, we have a lot of webinars, we have Zoom meetings, we are dying now. We are dying of WebEx and webinar and Zoom because we are zoomed out. But yeah, you know, we have a lot of that. So we definitely have continuous medical education. We call it CMEs. They are everywhere. I think every day there's someone somewhere who is doing a meeting, a virtual meeting, you know, to discuss coronavirus, you know, coronavirus in maternity, you know, in maternal patients, coronavirus in terms of breastfeeding, you know, coronavirus during delivery, you know, so there's a lot going on. I particularly want to applaud COGS. COGS is the Kenya Obstetrics and Gynecology Society. They release a webinar every week without fail. And it has everything to do with coronavirus and its relationship with obstetrics and gynecology. So with that, of course, and also KMA as well. I mean, I am in KMA, so I also have to give a shout out. Yeah, so they're also doing amazing. They release, I think, one every week or twice or two CMEs in a week. So in terms of knowledge, it is everywhere. Even WHO is doing the same thing. So we have a lot of knowledge. I think it would now, you know, the onus is on you as an individual, as a doctor, as a medical practitioner, as a health worker to get the information. The information is out there for you.
Wow, amazing. So, Dr. Eddy, you have heard what Dr. Wanjiku, sorry, what she's saying. Is it the same case when maybe in your practice as an ICU doctor, are you exposed to these many CMEs where you now enhance your knowledge?
Yeah, I think it's the same story because our working environment is almost the same as mine. We work in the same hospital, practice in the same hospital. Though we come from different departments, but sharing of information, the way she said, it's been a lot. And actually, you know, Africa was a bit late in reporting the initial cases. So by the time COVID was landing home, we had a lot of information. And I think just information sharing alone got us a step ahead compared to many other countries which reported COVID-19 disease. So I think it's really been a good thing. At the university, we're already having online classes. We're having webinar sessions, Zoom meetings, just with professionals coming, telling us this is how you need to handle yourselves when you're in such a scenario. In terms of technology too, like in my practice, we have a lot of hands-on duties, or our skills are mainly hands-on. But now with the advent of coronavirus, we are forced to start exploring other things which we used to just imagine these are there, but we can always manage without them. Like personally, one of the things you always do a lot is you work around the airway. Now, when you have to intubate a patient, we just used to have our what we call a laryngoscope. With your skills, you push in your tube, connect the patient. Now, with coronavirus, to minimize your exposure with the patient, we had to explore things like video laryngoscopy, fiber optic intubation. So, I think as a plus, this thing has also opened our eyes as people in Africa to try and explore some of these things we just used to imagine are there, but actually we can actually use them to also enhance patient care. Yes.
All right. Interesting.
Yeah.
Dr. Yonga, is this also helping maybe those doctors who are practicing from very interior areas in Kenya? Dr. Yonga? Dr. Yonga, can you hear me? All right, I'm sorry.
Yeah, actually, where I was speaking to a friend who works. I was speaking to a friend who works in one of those really far-flung areas of Kenya, and he was actually telling me that. Yeah, I can hear you.
Yeah, continue. Yeah, continue, Daktari. Proceed, Daktari.
Can you hear me?
Yes, I can hear you. Just proceed. Proceed. Right. I'm sorry. Maybe proceed. Just proceed. Yes.
Yeah. So I was actually saying that I've actually had a number of friends who actually work in the front. Yeah. So I was actually saying that I have a couple of friends who work in a number of areas who really have actually been asking me whether they have actually been dying by webinosis, just as Dr. Wanjiku was saying. And what we'll actually realize is that in a number of these areas, they were really not being covered properly by continuous medical education series. Because what was happening is that you find people were congregating either here in Nairobi, congregating in Mombasa, congregating in Kisumu or Eldoret, really the major cities, and sit in hotels for continuous medical education sessions. But now you find we're in a situation where I think not even every week, I think myself every single day, I think I tend to attend 1 or 2 webinars. I probably speak in a webinar per week as well, trying to give updates on the investigational therapies that are coming out for COVID-19. And so you find that in a number of those areas that they're now actually trying to be covered by some of these educational programs. The second thing you find is that when President Kenyatta launched the Google Loon project, whereby balloons that are being flown by Google really over some of these far-flung areas, particularly along Turkana and Laikipia counties, the internet stability has actually significantly improved over time. So find people actually attending 3 to 4 webinars in a day. And when you see what was happening last year, the Kenya Medical Practitioners and Dentists Council made it mandatory for doctors and dentists to be earning a minimum of 50 CPD points. Now, if you're in some of those far-flung areas, even attaining 10 points would be literally difficult. But I'm told now with webinars, people are actually overflowing with over 200 CPD points just because of the webinars that are being hosted. So I think some of these technologies have really come in handy. First of all, not only to get doctors up to date in terms of their registration requirements for annual retention in the register, but it's actually keeping people updated. I think for some of us in infectious disease, we've actually said if people are not learning from COVID-19 in terms of immunology, in terms of virology, in terms of pharmacology, because I think it has brought a lot of specialties back to the basics. If people are not learning all that, then I don't know when people will actually learn some of these.
Wow, amazing. Thank you for that, Dr. So I want to bring Kenta, because Kenta, this is maybe what we also try to build. Maybe can you tell us more about maybe startups, and also what as our startup is trying to work in terms of maybe supporting medical practitioners?
Okay, thank you, Patrick. The internet technology is bring the good opportunity to the African region, especially under this situation. So we will try. Our company try to develop to the development of the community between the doctor, and also beyond to the countries. And so Dr. Yonga is all every week participate our the web conference in the system. So I just want to show you our product a little bit. I would like to start the share screen.
Okay.
Yes. Screen. Can you see the screen?
Just a minute. I can see it. Okay. You can
proceed. Yeah. So this is our the product. It is the doctor developed the doctor community. So so Dr. Yonga is here. So we try to providing to the live conference to the doctors about the COVID-19 and also clinical case studies for enhancing of the skill and the knowledges. Yeah, and also providing the video contents, and also providing to the group for discussion. Yeah, then so also we providing to some news of the news of the industrial the information such as the medication or devices from some companies, and also providing to the medical news and the PubMed information. This is especially for COVID-19. It's a latest thesis. Yeah. So and also I really hope to develop to the group to discuss about treatment of each special the field, the treatment of the cancer, treatment of diabetes, treatment of the cerebrovascular disease or something kind of the special field. So why we developed this system to the medical professionals, because this situation should be sharing to the information each doctor beyond the countries. So because Kenya is one of the highest country in the East Africa, but around another country is a little bit lower the situation than Kenya. So I really hope to the beyond the border of the country is not be differences of the knowledge and skills. Not should be differences of the skills and the knowledges. So I really hope to the many doctors and medical professionals participate here to sharing to the information, the knowledge and skills. So of course, doctor have to get the CPD point, but we would like to provide to the beyond of the CPD point. So I really hope to develop to the higher skill between the medical professional and also industry, providing information to develop to your skill and the knowledge and for better health in Africa.
Right.
Yeah.
Thank you for that. So thank you for sharing that. So maybe I want to bring Alphonce where. So Alphonce, where we have been talking about maybe how technology can actually help us maybe advance UHC in the country. And one of the pillars of UHC is actually how we empower medical practitioners. So in terms of startups coming up to in this field, maybe to work to enhance the advancement of UHC, what do you have to say?
First, I think we need to be a bit careful when it comes to medical field because it has an element of emotion, it has an element of clinical touch, which those two may not be replaced by technology at all, even if we attempt, both in terms of training and in terms of actual practice. However, we have aspects that fusion of technology can assist. For example, what Dr. Yonga was talking about, the issue of or training or continuous development while at work already. You find that the issue of CPD points, you can actually learn virtually, but there are several medical things you cannot do virtually. So I think the first thing is to work closely. The startups that want to invest in this field of technology and medicine must work very closely with different professional groups within the medical fraternity or professionals, because we have around 17. I think there's a time we talked to a doctor, and I think we had something around 17 subspecialties within the medical fraternity, or up to 23 if you look at the furtherance of the groupings of this. So some of them, for example, people who deal with medical records, you find that the technology issue can actually be 100% sorted with them, so they can easily be fused. But if you look at maybe, let's say, a dentist or a gynecologist, there are things that they must be there. The doctor physically, even if they're in their house, they have to leave the house and run to where the patient is and have a physical contact. So the first thing is, what are aspects of this profession and this specialty in the profession that can be automated, that can have fusion with technology? Now, the best placed person is the doctor himself or herself to give the details of how this can be automated, on how this can be used with technology or fused with technology to make work easier, to make work better, to make work efficient and effective. So I think it will be a quicker failure if startups think that it will be automatic to make medical online or digital or automated. And it will also be a failure of medical fraternity, particularly at the leadership level and administrators of it, to think that we can actually do away without the medical professionals having a physical touch. Now, why am I raising that idea is because among the professions, and I think in this show I've raised the issue of professionalism, among the professions, most of what people do are not professional things. They are occupational things. So an occupation can easily be automated. An occupation can easily be done by somebody who did not go for a formal training and to completion. And therefore, they didn't need a license as a recognition that they have actually finished successfully the training. But for a profession, and medical is one of them, for a profession like medical, you must work with the medics. You must work with the virologist, for example, to understand various aspects of why virology is actually a specialty and not just another medical, not just another doctor, like the generalist. And the other issue is there are aspects, for example, if I am a teacher of biology, even if I get my PhD, I still remain a teacher of biology.
Okay.
But for medical professionals, when you are thinking of infusion of technology with them, one of the things that you need also to put in mind is that when a medical professional goes for a second degree, they have gone for advancement, and therefore they are becoming a specialist. Now, once they become a specialist, they will not practice as generalists when they come back. Now, you need to also understand that most of the administrators in the medical field don't understand such dynamics. And you find that now when we're having county government being in charge of the health human resource function, they still expect the doctor who left for further studies when they come back to continue being the general practitioner, which may not fuse. So I think involving the doctor, in my view, I'm not a doctor, they will correct me, but involving the doctor will be very critical in developing the solution that the technology want to address.
All right, thank you very much, Alphonse. So I want to go to Dr. Yonga because Dr. Yonga, in our case, maybe for Mediscan, of course, and other startups, they of course work with doctors or even with any medic or those organizations. Now, in terms of how we advance UHC, for you, what do you think maybe startups or even those who are advancing these solutions should keenly do, of course, working with medics?
Of course, when it comes to UHC, you will find that number one, the startups, one of the solutions that they are currently providing is in terms of the widespread, the wide outreach that they're currently having in terms of delivering educational content to doctors, pharmacists, dentists, and the like. So startups come up really well, and particularly in this scenario whereby movement is quite restricted, you will actually find that some of these startups, in working with doctors, particularly with regards to doctors who have certain knowledge and expertise in a particular field, be it in issues of reproductive health, be it in issues of critical care, be it in issues of child health. It's quite in order that some of the startups actually work with some of these professionals to try and deliver some form of educational content to people who work with these groups of patients. When it comes to issues of healthcare financing, it would also be nice if you work with probably healthcare professionals who've specialized in healthcare financing issues. There are professionals who've specialized in healthcare informatics. There are doctors who are taking artificial intelligence very seriously. I think those are people who really need to be involved, because as we move along, remember UHC was geared towards, I think, the year 2030. But now with this COVID era, you find that a number of these things are now being fastened very quickly. Issues of telemedicine, I think, were being talked about, were being talked of being rolled out in Vision 2030. I think right now, I know a number of my colleagues who are seeing patients via telemedicine. I know myself, I've seen, I think, 4 or 5 patients. I've actually been reviewing 5 patients remotely who've come down with COVID in Mombasa. And so they're being and we are reviewing some of these patients remotely. And so we're actually using certain forms of technology in terms of reviewing their chest CT scans, in terms of reviewing their ECGs, and that kind of thing. Now, when it comes to issues of startups, I think now when you integrate some of these technologies or some of these diagnostic tools within the startups, I think it comes in quite handy in trying to guide the clinician or the public or the medical professional who is trying to sort out some of these patients, so that they actually try and give some form of holistic care. The second thing is that startups can actually attach maybe a specialist with a general practitioner who is probably working in some of these far-flung areas, and they can actually work together in trying to sort out some of the complex patients that they may be handling in some of these areas. And these are things that I speak through from experience. There are some startups that literally were set up, but because they did not involve any healthcare professional, 1 year down the line, we don't hear of them nowadays. But I think for startups, I agree with Alphonse that when some of these startups are beginning, or when some of these startups are actually moving along the way, it will be nice if you involve the healthcare professional at various specialties, because it is not only COVID that is ravaging us. Of course, right now, for infectious disease, a lot of us are busy because of COVID, and then there's also cholera ravaging through some of the places with floods. But we'll find that there's issues of reproductive health in the COVID era. There are issues of how do you take care of patients in the critical care unit? How do you take care of patients with eye conditions who have come down with COVID? All these professionals need to be consulted. And some of them, they may not be able to travel, but by remote consultation or by remote delivery of educational content through some of these startups, I think we'll be doing a lot of service and a great favor to some of the clinicians who are working in delivering universal health coverage in some of those facilities without necessarily a specialist having to travel all the way.
All right, that's really interesting. Thank you very much, Dr. So I want to move to Dr. Wanjiku. So Dr. Wanjiku, maybe can you share with us in terms of actually the uptake of you as a doctor or even your colleagues when it comes to getting this information, maybe drug information online, maybe clinical trials. Of course, you have shared about attending CMEs and many of them, and even research. How necessary is this information for actually medics?
All right, so thank you for that question. Okay, we normally say that the only time you stop learning is when you die. So learning never stops. You can never say you've gotten to the heights of medicine. So you always have to keep yourself updated with the latest information, latest clinical trials, what is happening out there, you know. So I don't think there's any doctor who can ever say that, you know, we are now somewhere like we are the best of the best. Never. Medicine is always evolving. We are always creating new stuff. We are always experimenting and trying and doing so many clinical trials. So that's why I said it is upon you as an individual, as a medical practitioner, as a doctor, as a specialist, as a consultant. The honors are on you to make yourself better, keep yourself abreast with the updates. So yeah, I mean, it's just on you. I wanted to talk about something. I mean, just to piggyback on what Dr. Yonga said about telemedicine. It has pros and cons, you know. And truth be told, this is where we are heading, whether we want it or not, you know. So, and change is the only constant in this life. So about telemedicine, I'd like to say that there are some pros, you know, in terms of there's less waiting time at the waiting bay. You know, you're not physically waiting to see the doctor. So that's number one. There's also the convenience of you can talk to your doctor, to your e-doctor, anywhere, anytime, so long as you have internet with you. There's also the fact that there's cost efficiency. The only thing you need with you is a few bundles, you know, and then you have that interaction. But also, I'd want to say that just as Dr. Yonga has said, somebody like things like the reproductive health, the dentistry, and even infectious diseases. I think I mean, because you know we were always told in undergraduate that an exam is not complete without a physical examination. So I could ask you your symptoms. I could probe you out. You know, I could probe you, and then I could perhaps have an idea, but that's only history taking, you know, and the body and the meat of making a diagnosis is actually in touching the patient. We were always told if you've not touched the patient, you have only done 30%. So there's only so much telemedicine can do. I am not discrediting it because it is important. And of course, it can help us to gauge, you know, like we can tell you with these symptoms, please rush to your nearest health facility. So of course, I'm not discrediting it because it can get the information out there faster and even create an awareness. But also I would not, you know, I would overemphasize, you know, I can really overemphasize that an examination on a patient is not complete until you touch that patient. You have to listen to their chest. If it is it's an abdominal issue, you have to touch the abdomen. You gotta use the stethoscope. If it's an ENT surgeon, they have to use their otoscope. For me, I use my fingers. So yeah, and a speculum. So yeah, that's what I want to say about the telemedicine. But in terms of your earlier question, just to reiterate, is that the onus is on the medical practitioner to actually look for the information. It is actually everywhere. Even right now, because I'm a postgraduate student with Dr. Mboya, and we are actually doing our virtual sessions, you know. So we are doing the Zoom, we're doing the webinar, we're doing the WebEx. Information is everywhere. So you really have no excuse to not be updated, you know, unless you don't want to practice, you know. There are doctors who don't want to practice and perhaps want to do something else, and that's okay, you know. So, but if you want to be a doctor who's in clinical practice, it would be good if you actually, you know, keep abreast with what is going on in the world, in the medical world. Thank you.
Wow, amazing. Thank you very much, Dr. So I want Dr. Mboya. Of course, we are saying technology is not going to replace doctors when it comes to patients' journey. That's obvious. But what technology is going to do is to enhance the work and even to make it easier. Now, my question is, maybe for your own practice, which is now ICU critical care, in terms of you, what are some of the challenges that maybe you have come across while trying to actually incorporate this technology?
Okay. In my practice, I think, okay, managing of patients, we need machines, we need things which are current, we need new protocols. So I won't really say there are specific challenges we face based on technology, because okay, I know there are those good things, like in terms of sharing information, the way Dr. Wanjiku has said, linking up labs, linking up radiology, linking up maybe patients' documents, meaning like if I'm in a single ICU, I could be able to review a patient just looking at the documents in a computer. Patient I'm not with currently, then I'll make a decision very fast that by the time I'm meeting this patient, I know what probably what I'm supposed to be doing. The only thing with our current setup or where we practice is probably the availability of some of these systems and the equipment. The technology is there on how to share information, on how to handle some of these things. But I think in our setup, the main challenge I'd say is the availability, because you'll find there's a procedure out there that can be able to change a patient's outcome or a patient's prognosis or the patient's management, but you don't have it readily available. By the time you get it, it's probably somewhere else in a different hospital at a different or at a higher cost, which at times is out of the practitioner's reach or out of the patient's availability in terms of cost. So I think those are some of the issues that we have, because I can only talk about where I work specifically, because that's the experience I have currently. So most of the things out there, we get to hear about them, like probably issues around radiology. There is some level of scanning that we'd wish to have done to some of our patients, but we don't have it at where we work. So no, I think those are some of the major issues that we face. Like now with the issues of COVID-19, I won't really call testing the coronavirus is we need technology, new technology, but from some of the readings we've been having from outside, there are those machines which can give you results quite fast. Yeah, but you know what currently we have is we get our results with after 24 hours or even more. So, you know, even if you wanted to screen patients before doing certain procedures for the safety of the doctor, for the safety of the other patients, you know, some of those things are not possible. So you find a patient has to wait, or you take extreme measures for a patient who's probably negative for COVID-19 disease. So those are some of the issues. So I guess we are still playing catch up to managing this disease and other illnesses. But I know with time, with now the coronavirus has opened our eyes and has exposed us to different things going on out of these countries. So I believe with time we'll be able to have those things also around our shores and available for us to use. Yes.
Oh, great. Thank you very much for that, Dr. So, Kenta, maybe I want to come to you, especially when it comes to the role of AI, and especially for avoiding or when we come with in terms of misinformation, where we have the maybe wrong information shared, maybe controversy shared. Is Japan having any policy in terms of AI where it's helping healthcare system to actually help in enhancing correct sharing of information, especially now that we have cases of COVID-19 misinformation?
Okay, thank you, Patrick. In Japan, if difficult doesn't do the diagnosis of the patient, so just the AI is just the supporting to the doctor's decision make. So much of the startup company and some medical company providing to the AI services for the doctors. But the most important resources is a doctor. So AI just artificial intelligence just supporting to the doctor decision make. So and also the sharing the information is so much of the startups also providing the sharing the information. For example, doctor sometimes difficult to make a decision for this diagnosis. So doctor can ask the specialist of the doctors, and also a doctor sharing to the information of that. And also some companies providing to the pharmaceutical companies, the medical device company to doctors. So maybe it helps to the better the understanding of the medical information, the device information. So maybe the Kenya the medical company try to providing the doctors, but maybe have some little bit issue to the between the industrial area and the doctors and medical professionals.
All right, interesting. Thank you very much for that. So, Dr. Yonga, especially now that we are in a crisis of COVID-19, and when we are talking about AI, do you think AI could actually do a lot of service to us where we are to avoid a lot of misinformation to the public? And if we could have AI actually maybe implemented in Kenya?
Actually, AI is already in use in Kenya. In fact, when you hear the Ministry of Health telling you that that during their projections that this number of people will be infected by this amount of time, like when they told us in April that within the first week of April, 1,000 people will be infected. By mid-April, 5,000 people may be infected. By the end of April, 10,000 people may be infected in case anything is not done. That is actually AI they are using, because that is mathematical modeling. Mathematical modeling is purely based on artificial intelligence, and we are using it quite a lot in epidemiology, both field epidemiology and clinical epidemiology. We are using artificial intelligence a lot when it comes to issues of predicting whether patients coming in with various infectious diseases will develop antimicrobial resistance. We actually do modeling to see how many people we may actually come down with some of these things. So I can say in infectious disease, we are using it a lot. In other subspecialties of internal medicine, like cardiology, a lot of artificial intelligence is also being used to actually predict in terms of patients who come in with certain comorbidities, particularly if they're coming in with increased fat, that is increased lipids, coming in with various risk factors such as diabetes. We can actually predict using artificial intelligence when some of these people may actually develop, say, heart attack. In medicine, we call it a myocardial infarction. All these are based on artificial intelligence, maybe just because a number of people may not know that some of these newer technologies are actually based on artificial intelligence, how to predict when people will actually probably come down with certain comorbid diseases such as chronic obstructive airway disease. All these are modeled based on artificial intelligence. So it's already with us. I think the only thing that has not really taken place properly is the uptake and the training of medical practitioners to actually understand a lot of how some of these technologies work. But I think that is one opportunity that even startups can actually help in terms of navigating some of these complex waters. And it also diversifies some of the practices that us doctors actually use, because it actually helps you in, like, for example, what the Ministry of Health has been using in terms of their modeling data. You know, it has helped them a lot in trying to put in certain interventions, and it also helps them in what amount of testing they're supposed to do to actually make sure that they get to those numbers. So one of the things that I do agree is that some of the modeling data that they've been using has helped a lot with issues of contact tracing, with issues of trying to calculate your reproduction number in terms of how one person may be able to, how many, on average, how many people one person could infect. So artificial intelligence has really helped in that front. I think what has really hindered the Ministry of Health from intervening further has been issues of the inadequacy of tests and the inadequacy of some of the reagents or some of the capacity to really dig deep. But already one of the things that is encouraging that they're already using some of these technologies. In fact, when I heard that there is already modeling taking place in the Ministry of Health, myself, I was very shocked and surprised because these are technologies that are not used quite widespread. But a number of countries use this to try and project their morbidities and mortalities from various diseases and various complications of diseases. So I think it's something that we should really take in quite aggressively.
Great. Thank you very much, Dr. for confirming that we're actually using artificial intelligence. It's very good. I want to confirm from Dr. Wanjiku whether she has actually interacted with artificial intelligence and how maybe it has enhanced her decision-making in the practice.
All right, so thank you, Patrick, for that question. So first of all, we actually even need to understand, or rather our audience needs to understand what artificial intelligence is, because I want to assume not everybody logging in is a health worker. So I'll just read the definition. Artificial intelligence, or AI, is defined as the use of complex algorithms in order for machines to either reason and to perform cognitive functions, including, problem solving, problem shooting, and also helping decision making. Yeah. So for anybody who's watching and perhaps is wondering what is this artificial intelligence, yeah. So it's just a complex of algorithms, yeah, that are doing what you would have done, manually, but now of course we're using machines. So to answer your question, we have artificial intelligence in obstetrics, where we use the cardiotocography, that is a CTG, and the CTG monitors the fetal heart, and it also helps us to monitor the uterine contractions when a woman is in labor. So this is a very great tool. Studies, I think, as back as 45 years ago, showed that CTG is accurate to a measure of 60 to 65%. And so that is above 50%, and that is really, really good, So if we see that the fetal heart rate is either accelerating or accelerating away from or deviating from the normal, then we are able to intervene to save both the baby and the mother. So that is artificial intelligence in obstetrics. We also have artificial intelligence in gynecology, especially in the gyne-oncology, yeah? So cancers in the reproductive area, that's what we call gyne-oncology. And this is what we base it on something we call the FIGO classification, where we are able to rate you as stage 1 cancer, stage 2, stage 3, stage 4, like that. So you see, artificial intelligence has been with us for a very, very long time. Perhaps we just don't call it AI, but it's been with us. And lastly, of course, now we have infertility with us, So of course, assisted reproductive measures and the IVF, in vitro fertilization, we are using AI, of course. So yeah, that is what we are doing in the Department of Obstetrics and Gynecology. So for obstetrics, it's the CTG, that's the cardiotocography. In gynecology, is mostly in the oncology area, where we are classifying tumors according to the FIGO classification. And for infertility, then we have the IVF, and the assisted reproductive technology, the ART. Thank you.
Amazing. Thank you very much. Maybe up to there, I want maybe to bring Alphonse. Alphonse wants to ask a question, but specifically Alphonse can specifically ask a doctor or a Kenta a question. Then once he responds, I'll bring another person who is interested to ask a question, and that's how we move.
I'm a father of girls and a husband to a lady. So Wanjiku might be my first client here. So thank you. I'm interested in the issues to do with the handling of expectant women, and also the issues to do with birth. And I've observed, particularly in the rural setting and informal setting in the urban centers, a good number still don't take the clinics very seriously. And when they are going for delivery a month, 2, or just the very time they're going for delivery, there are some specific records they are supposed to have and they don't have. So how can we use technology and also specialized care from your field, Dr. Wanjiku, to ensure that we assist these mothers and we also teach them and talk to them the language they can understand, but also use that technology so that if the issue is movement or going to queue, I've seen, I live in Nairobi, and I've seen a public hospital here, people queue and they're told come back tomorrow, and they just get tired, and sometimes they decide never to go because of how they are mishandled. So I want to hear your view on that one.
All right, thank you so much for that question. So I think there still needs to be a bit of innovation in that sector, because, and yes, you are right. Actually, people in mashinani, well, there's some improvement, I want to say. Especially, I think there's the program Beyond Zero by the First Lady of this country that was trying to, to mitigate that, in terms of transportation, education, and all that. But I still believe that there's room for improvement in terms of, trying to tell the mothers, that you need to come to hospital. Actually, the WHO recommendation for antenatal clinics right now is at 8 visits. Meaning, if you start going to the clinic at 14 weeks, you come 8 times until maybe when you're 38 or 39 weeks, because gestation is 40 weeks, which is equals to 9 months. So there's still a lot of room for improvement, and so we are counting on, our fellow colleagues who are at mashinani. I am also one of them. I just came to the big city to just get some education, to get my master's degree, and then I will go back. So, it's people like me and my colleagues who will team up together and see how best, especially to work with community health workers, because these are the people who actually go door to door. Just the same way we have a lot of exposure to the polio vaccine. I'm sure you've seen these polio vaccine people. They are so vigorous. They go door to door. They write on your gate. They write on your door. They can come even up to 50 times. So I think if we would engage, if doctors, nurses, paramedics, everybody would engage also the community health workers, and perhaps to sit down and see how best to engage so that we can educate mothers, on the importance of attending the antenatal clinics, and also perhaps enhance transportation to the clinic or health facility closest to them. And at this juncture, I actually want to digress a bit and actually say that there's a colleague of mine and a classmate of mine, she's called Dr. Jemima Karaoke, that has come up with an initiative that is brilliant. It's called the Wheels for Life, where we actually are transporting any mother within Nairobi County to their hospital of choice during curfew hours. That is between 7 p.m. to 5 a.m. You just call the toll-free number, that is 1196. And once you call that number, there's somebody who will receive the call. The line is working. Kenyans, Kenyans are so funny. I'm sure there's somebody who has taken that number to just call and make sure it's working. Imagine it is actually working. Yeah, so that's a number you call. So you call the toll-free number 1196, and you can get your expectant wife, sister, mother to the hospital within curfew hours. That is 7 p.m. to 5 p.m. 7 p.m. to 5 a.m. And it is actually absolutely free. We've done that in a collaboration with Bolt, that is former Taxify. We also have AMREF. We have University of Nairobi, Kenyatta National Hospital. We have a lot of partners. So, that is also one of the innovative ideas that are coming up. So we need more Jemimas, and more Wanjikos like me to come up with such innovative ideas to help our mothers. I don't know, for some reason, I don't know whether there's any statistic, but for some reason, obstetric emergencies happen at night. And also for some reason, babies are conceived at night. So there is something about the night time. Yeah, so I think it's basically just to wind, to summarize what I'm saying is we need more innovative ideas from our doctors and even from partners of doctors and nurses and medical practitioners at large to be, and also community health workers to be able to get to our mothers, especially and to even educate them on the importance of going to the antenatal clinics and to educate them on the danger signs during pregnancy. Thank you.
Thank you very much.
Let me confirm that I actually called 1196 for my sister this week. And my sister was delivered this week. Yeah, the call was at 11 p.m. and she was picked from her house.
Wow! Congratulations.
So just for those who are doubting, it is working. I'm a beneficiary. I called them for my sister. So, and it was absolutely free. So thank you. I didn't know who was the brain behind it, but it's such a good idea.
Yeah. Her name is Dr. Jemima Karaoke. I think she's watching this, and she's my classmate. Hi, Jemima.
Yeah. Now, just one more to in your field again, Dr. Wanjiku, is that as we are talking of this, one thing that is coming is in your field. I'm made to understand that we need. I'm not a specialist at all. I studied agriculture, so I have nothing to do with human beings apart from being a human being and living with them. So here is a situation where I grew up in the village, and I remember my mother helping so many expectant women. So she was called a midwife. So I thought midwifery is inherited. You are trained in the village to become one. But then when I was coming to school, I'm told these people are supposed to be trained. Now I am discovering that in our country, we don't have formal training about it. I want just to get clarity about that and what should be done about midwifery and whether it is important or we should ignore it, and what we should know. Both the policy people who are listening to this, I'm very sure this may not be automated. Is it very important, or as long as we have you and your colleagues, then it is done?
So I think you want to talk about the midwives. Actually, midwives are trained nurses, and then we have the traditional birth attendants, and then we have the doulas. Yeah. So those are three different categories. So midwives are actually nurses who have undergone the nursing training. They either have a diploma in nursing or they have a bachelor's, a BSc, a Bachelor of Science in Nursing. And then now we have the doulas who actually do home births, and we have the traditional birth attendants who are like our grandmothers, who they learned this midwifery through apprenticeship. Yeah. So of course everybody is important. We can never discredit anybody, because I cannot reach everyone. Me as Wanjiku, I cannot go to Mandera. I cannot be in Wajir. So we need everyone. But I think what I'm emphasizing here is we need teamwork. That traditional birth attendant, that doula, that midwife, that obstetrician, that general practitioner, medical practitioner, that clinical officer, everybody needs to, there needs to be like a protocol of sorts and a system that is working for them to work together. Because remember, not every birth can be done vaginally. There's somewhere we get emergencies, and so that would mean that we get into a theater and we do an emergency cesarean section. And a cesarean section, God forbid, should never be done at home. No matter how no matter how much you'd want to help the patient, it is really, really advised that the cesarean section is done in the hospital. So I mean, what I'm emphasizing is everybody needs everyone, and it's teamwork. I don't want to say that the obstetrician is like ahead of everybody. No, he's just a team. He or she is a team leader, but the obstetrician needs a team. Like for me, for example, I need the nurses. I cannot work without them. I need the midwives. Because they're the ones who actually receive the patient, they triage the patient, and they actually follow them through. And in case of anything, then they call me. I also come and see the patient as well. And also for the clinical officer. So everybody needs to work together. I actually want to applaud doulas, home birth deliveries, where you actually, I think there's actually a center, And I think I'll actually shout out to midwife Lucy Mushiri. I think she's been doing this for the last 20 or 25 years, if I'm not wrong. And she has had success rates, and she has obstetricians that she is collaborating with, so that in case the mother she has in the home, maybe like in the water bath, yeah, perhaps if she notices that there could be a complication, she has already planned on how they can transfer her to a medical facility. So what I'm emphasizing is teamwork cannot be overemphasized. We need everybody, and everybody needs to work together.
Thank you. Thank you very much. So, Alphonse, I'll just hold on a little bit. So I'll maybe get more guys to ask a question. If there's any question, I'll bring them to the screen, and then I'll bring you back to continue with questions. So if anyone have a question, you can actually type it on the comment box, or actually you can join using the link. We'll ask our participants your question. All right. So I want to bring Joyce first. Joyce, how are you? Joyce, how are you? Can you unmute your mic, Joyce?
That is my mother. She's so excited to see me. Hi, Mom.
Wonderful.
Yeah, so she's just excited to see me. I don't know whether she has a question.
That's good. No problem. Wow, amazing. You have the support system here. Doctor, I'm glad, yeah? So, Nina, how are you? Nina, how are you? Can you unmute your mic? Hi, Nina.
Nina, thank you for the registration of the website. Thank you.
All right, Nina, you can ask the question now. You can specify who the question, who should address the question. Nina, can you unmute your mic? Okay, I think she has an issue with the mic, huh? So maybe I'll bring her. Okay. Nina, I still want you maybe to ask the question. Can you ask the question? All right. Okay. So maybe before I bring Wekesa to ask a question, there's a question to Dr. Mboya. So Dr. Mboya, there's a question from Sylvester. Sylvester is saying, how can AI be used in anesthesia?
Okay. Thank you, Sylvester. Some of the, mostly my area of practice is mainly, that's anesthesia in theater, giving general anesthesia, regional blocks, or spinal anesthesia. And my other area of work is mainly in ICU. Currently, where I've seen AI applies is in mechanical ventilation. We have some of these latest models of machines that are able to integrate the patient's condition and adjust themselves according to how the patient's parameters are. That is, a patient needs this level of support, a patient needs this level of oxygen. The machine is able to detect, adjust, and let us know what we need to do about those. Because previously we used to have, we put the patient on the machine, or even currently, some of the older machines we have, put a patient on the machine, keep testing the patient, looking at the parameters that you're interested in, then you manually adjust everything. But some of the machines we currently have, they're able to detect whatever device you want to connect the machine, the patient through, then the patient's condition. Like in COVID-19, most of these patients present with what we call ARDS, acute respiratory distress syndrome. So there are specific parameters that you need to set in the machine to handle this patient. But some of the current machines that we have some of these ventilator settings that are able to sort out an ARDS-like illness and take you through this patient up to the point of weaning, and now guide you on how you're able to, on when to extubate the patient or let the patient breathe on their own. So in theater, I don't think we already have them over here, but we have some modules of administering general anesthesia. like what we call total intravenous anesthesia, based on studies and models which have already been come up with. We know that there are specific dosings that when you give, keeps the patient adequately anesthetized and with minimal overdosing or the patient being aware during surgery. I think this is a model of artificial intelligence, because we already have some of these, what we call perfusion, infusion pumps, where you just set a patient's age, a patient's height, a patient's weight, and the kind of drug you're using. Then based on this, the machine adjusts and keeps your patient adequately anesthetized up to the point of surgery. By the time the patient is coming out of surgery, you have minimal drug overdose, minimal side effects, and minimal, let's say, toxicity to the patient. So I believe these things are already there. Unfortunately, in some places we're already using them, some places we aren't using them, but they're already around, and we already have them in application. Yes.
Thank you very much for addressing that, Dr. So maybe I want to bring now Wekesa. Wekesa, when you ask your question, you can ask specifically to, you can ask who should address that question also. Wekesa, can you unmute your mic?
Okay, I think my question will go direct to Dr. Eddy. We have different kind of technologies that we can implement in medical fraternity. But mine, since I come from the field of sales and marketing, I'll focus on technology that affects logistics. And we have seen recently Ghana was able to round up their testing because of the technology they were using in terms of the quick implementation of the testing. They used the drones. We are told in military there are even drones which are equipped with artificial intelligence. I'm not sure in Kenya how far we have gone in terms of thinking about drones, because I hear even Ghana up to around 1,000 facilities had drones that help them to get samples from the local villages and then to the places they are required. So that's how they were able in 3 weeks to end the lockdown. What is your take?
All right.
Thank you. Thank you, Ekes. Locally, I don't think the government is already exploring that, because I'm seeing Dr. O.Yonga has left the meeting, but being an infectious disease specialist and somebody who's been interested in testing and getting some of these patients known and bring them to the hospital, I feel it was better placed maybe to respond to this. But my experience locally is the government goes out to look for trace contacts and suspected cases, actually pick the samples and take them to the testing areas. So sending out drones out is I don't think we're already applying much technology to try and get patients tested. We actually physically doing it, getting those people out to people from the labs out to pick up samples, no matter how many they are, sending out people to the communities, to the hospitals where we have suspected cases. I'd applaud Ghana's efforts in handling that disease, but locally I don't think we are doing that. But Dr. O.Yonga being in that task force on how we're handling coronavirus, I think would have been better placed. You would have had more information on some of the strategies that the government is employing. Basically, that's what I have to say. But unfortunately, he stepped out from what I'm seeing. Yes,
have some network hitch, but he will come back. So we can go to Nina now. Nina, can you ask your question? And you also specify who should address it. Sorry, Nina, we cannot hear you. Nina, I'm sorry, can you unmute your mic? All right. I'm sorry, we cannot be able to hear you. I'm really sorry. Maybe since we are unable completely to hear you, you can just type it and then I'll read, and then maybe the panel will address it. Right? All right. Thank you. So I'll bring Alphonse again. Alphonse, please ask now a question. Maybe now you can ask the rest of the team, since now you have asked the only lady in this discussion. Sorry, unmute your mic too.
I should have a chance to ask.
Sorry.
Wanjiku gets more questions. Are you able to hear me?
Yeah, I can get you. Yeah.
Yeah, but I'm interested in Yonga's specialty. Now that we are in COVID-19, and it looks like he was waiting to work, and the work has come. So, Dr. Yonga, from your profile, I read that you are a specialist in infectious disease and tropical. Now, I don't want to call myself a layman, but we as the common mwananchi, tell us, what is this infectious disease and how is infectious disease different from contagious ones? And what should, because you see, we are doubting as a public at this point. We are thinking this is a political tool. We are thinking it's an economic way of gaining money for campaign. So from a specialist perspective, I want you to address us as the public. Is it true that this thing is that serious, or we are just being duped so that the government can joke with our minds? Infectious diseases, how are they different from contagious diseases? What we should take serious about this, if anything, and if nothing, tell us there's nothing to take serious so that we can go on with our lives.
All right, Dr. proceed.
Yeah, that's a very interesting question. So, okay, maybe I can just describe. So, infectious disease and contagious diseases are really one and the same. Infectious disease, communicable disease, it's really the same. Tropical diseases are still infectious diseases, but they can actually be divided. So it's still, but the majority are still infectious diseases. But they're really infectious diseases that are found in the tropics, like now literally below the equator. And so when you talk about infectious diseases, right now we are talking about, of course, COVID-19. But we also have infectious diseases such as viral hepatitis A, B, C, D, and E. We still have infections such as HIV. We have infections such as tuberculosis. We have infections such as syphilis, your sexually transmitted infections. So all those are infectious diseases, and the infectious diseases are quite broad. Now, when you come to contagious diseases, now some infectious diseases can actually be quite contagious. Of course, if you are a patient and you come to me and you've probably lived with HIV for a while, and you're adherent to your antiretroviral therapy medications, we normally suppress your viral load to such a point that you do not become infectious. So you literally cannot transmit the infection from one person to the other. So HIV infection at that point ceases to be contagious. But now when you look at infectious diseases such as the coronavirus that causes COVID-19, or infectious diseases such as influenza, those ones are now viral infections, and those ones tend to be quite contagious, particularly in populations where people are not immune. When you look at now the coronavirus, first of all, every person is susceptible because, number one, there's no vaccine, and normally vaccines tend to allocate some form of immunity towards particular infections, and that is why that worry is there, because number one, because of that lack of immunity, and number two, because we tend to live in a population where, because of solidarity, we're living with our mothers and fathers, our grandfathers and grandmothers, our relatives who probably may have certain immunosuppressive disorders or certain non-communicable diseases that literally render you, when they do get such infections, it becomes very complicated and very challenging to manage some of these people. And when they get it, that's where our challenge comes in. And those are during the early phases of infection. Right now, we are seeing even people who are normal, who are healthy. For example, the whistleblower, the whistleblower Chinese ophthalmologist who contracted disease and eventually passed away. May God rest his soul in peace. When some of these things normally now happen, it now tends to give some of us infectious disease specialists some form of worry, because now we are not sure. We cannot really guarantee that if you have this certain form of NCD or this certain form of existing condition, that yourself you will also get a lot of challenges managing the disease, and that is possible because every person right now is susceptible to getting the infection and is also susceptible to getting severe disease and eventually dying. So this is an infectious disease. Of course, when you compare them to other infectious diseases, some of them are more lethal than this one. For example, if you got measles and the measles became very severe, you may not get out of it. If you got an infection such as hepatitis A, then went into liver decompensation and go to liver injury, in some severe cases, you may need liver transplantation. And of course, that is not something we are doing. So when you look at some of those other infectious diseases, they are much more lethal than COVID-19. COVID-19 is causing us a bit of worry because number one, it's very contagious. Number two, it tends to affect the very afflicted of our population, that is, and the very neglected of our population, that is the elderly and people with certain NCDs. So this is something you should definitely worry about. Maybe not for yourself, but for the people who are around you.
All right. Thank you very much.
Maybe one more. Still to Dr. Yonga, we have been told that COVID-19 is a virus that within the group of coronaviruses. Now, we have in real normal life for us who live in Kenya here and our normal life, we have never come across these so-called coronaviruses. And therefore, it is part of what is affecting our behavioral change, which is affecting how we respond to the call, whether from medics or from government or other authorities. Now, just quickly and briefly, tell us, as the public, have we ever suffered of any of the coronaviruses in the recent past in Kenya and globally? And what do we need to learn from what you people already have? That's one. But part two of the same question, there's an obsession, and allow me to use the word obsession carefully, but also seriously. There's an obsession about having the vaccine as a way out. Now, having been informed that this disease has similar way of behavior in my body as my normal flu, which keeps on recurring. So how effective can we talk about its vaccine, assuming that we got a vaccine today, given that we have seen even polio vaccine being given so many times? Yeah, so just educate us a bit about the vaccines, assuming we even got one today. How effective will that be?
Yeah, I mean, those are fantastic questions. I think I'll start with the last one. So one of the things that you are going to realize is that one of the things you literally realize is that the vaccine is definitely the holy grail to any viral infection. As much as possible, you really want a vaccine to be able to give, at least not even yourself, but you need to generate some form of the so-called herd immunity that people are talking about, whereby you want a certain number of people to have some form of immunity so that other people may not literally be protected from that infection. Now, when it comes to the issues of developing a vaccine for this specific coronavirus, one of the things that you will actually realize is that a lot of the vaccines that we have floating around, they are not 100% effective. And that has to be clear. For every infectious disease, all the vaccines that we have are not 100% effective. But they give you some form of immunity so that you cannot be able to, first of all, get the infection. And number two, you are not able to transmit these infections to other people. So I'll give you an example. When you look at the current influenza vaccines that we have in the market, the influenza vaccine is probably 50 to 60% protective. And then the second thing you'll find is that there are very many strains of the influenza virus. So if I vaccinated you against, say, H1N1 that caused problems in 2009, probably there'll be the avian influenza that comes from chicken. And when you get infected with it, that vaccine may not be protective against it. The same thing with coronavirus. Coronavirus right now, there are 3 strains that have caused problems, I think, with very high levels of mortality. Number 1 was the SARS coronavirus 1 that emanated from Guangdong in 2003. Then we have the Middle East respiratory syndrome coronavirus that started in Saudi Arabia in 2012, and it has literally been overshadowed, because even as we speak right now, that is a coronavirus that is still spreading within Saudi Arabia. And I know my research team is currently working on some of the predictors of mortality for this. And then currently we have this coronavirus too. Now the problem with this one is because number 1, it tends to be very, as I mentioned, it tends to be very contagious, and then number 2, tends to affect the most afflicted of our population. And we realize that the population of people now getting certain NCDs is growing. And so when some of these people get the infections, how you're going to get out of it is really it's literally 50-50. It may not be possible how you're going to come or get out of it. And so that is why the vaccine may come in. But that is to say that it may not be the way out, because the vaccines that may come, it may probably be 60-70%, but all the other behavioral measures will matter a lot. Issues of hand washing, issues of making sure that you respect your personal and proper personal and respiratory hygiene. All that will be taken into context in conjunction with the use of the vaccines. And of course, with the use of vaccines, so long as there's some form of immunity, even the issues of physical distancing will actually be eliminated. But right now, in a population where people are not immune, that physical distancing, as well as respecting some of the proper personal and respiratory hygiene measures, really come into play quite effectively. Right. Coming to your question on coronaviruses globally, I think as Kenya and as a continent, this is the first time we are really experiencing a coronavirus infection. When you look at the others, we literally did not suffer as much as compared to this one. In fact, the MERS coronavirus, I think it's literally concentrated within the Middle East. But when you look at other countries such as the UK, Canada, and I think the US, they've only experienced 1 patient each with the Middle East respiratory syndrome coronavirus. But with this current one, only 2 countries have been spared so far. And so that's the challenge where the current coronavirus comes in.
Yeah, right. I know Patrick want to go to next move, but just allow me to finish with Yonga just briefly. Being a virologist and epidemiologist, I think there's something I've also learned about this space. Now, this type of disease, from what we are learning also, is that it emanated from other animals other than human beings. And therefore, I was told that such situations are called zoonotic diseases or conditions. I've also learned that we have virologists and epidemiologists also who are from the vet side of medicine. Now, for the sake of disease management, control, and all that surrounds that, how is your field collaborating with the medicine in the vet side to ensure that we have a holistic approach towards this type of situation?
Well, first of all, to correct you, I'm not a virologist. I'm actually an infectious disease specialist. So an infectious disease specialist, remember, infectious diseases are of 4 types. We have bacterial diseases, which is bacteriology. We have the viral infections, which is now virology. We actually have fungal infections. That is a specialty called mycology. And we also have parasites, which are also infectious, and that is what we call parasitology. So myself, I find myself in literally managing patients who come in with either of those 4. Now, to come to your question, there definitely is a lot of collaboration. Now, of course, you know of the issue of One Health, because One Health is the situation where human health and animal health tend to interact. Because you'll find that some of the pathogens or some of the infections that will cause a lot of worry in terms of global health security are actually zoonotic infections, literally infections that have jumped from animals into humans. When you look at issues, when you look at the avian influenza, H5N1, that it actually comes from chicken jumping into the human atmosphere. when you look at all the other coronaviruses, when you look at the Middle East respiratory syndrome coronavirus, it actually comes from the dromedary camels. When you look at the initial SARS coronavirus 1, it actually came from the civet cats. So there has to be some form of collaboration, and already that collaboration is ongoing. I know, like when they were trying to screen for any mass coronavirus carriage in camels in Kenya, the vets and the infectious disease specialists have had to collaborate on that one, because the moment it jumps from the animals and comes to human, it's completely disastrous. And when you look at the global health security agenda, I think it was ratified in Kampala in 2018. One of the biggest clauses in the global health security agenda is to actually try and look for some of these pathogens in animals. It's just like in the military. You need to know your enemy before your enemy knows you. And for you to know your enemy, there has to be some form of investment in terms of research to actually find what kinds of pathogens are actually running in these animals, if it jumps into humans, we face a similar problem such as this. And that is why initiatives such as CEPI, the Coalition for Epidemic Preparedness Initiative, which is a collaboration between the World Bank, the World Bank, the World Economic Forum, and the Gates Foundation, have actually collaborated to try and see if we can actually be able to pick some of these pathogens in animals and start making vaccines early enough, so that by the time some of these pathogens are now jumping into humans, some of these vaccines are already in place. So already there's a lot of collaboration. I think probably the only thing is to really streamline and to really make sure that there's some coherence in how some of these collaborations are actually undertaken. But I think in infectious disease, I know myself, I'm a very big proponent of One Health, whereby people who are undertaking infectious diseases in animals and people who are undertaking human infectious diseases treatment and research really have some form of synergized approach to how we form a common research agenda and how to really foster the global health security agenda as well.
All right. Thank you very much. Alphonse, thank you for your questions. I really want to move to now the winding up this session. But before that, there's a question to maybe Mediscan, our service. So there's this question from Nina, which is saying, Kenta, you can address it. She's saying, in keeping up with the changes in medical field, how do we balance implementing the new changes and abiding by the legal requirements, considering the Western world are usually ahead of us?
Okay. So, Patrick, do you have any opinion to this?
Yeah. So basically, what I will say to you, Nina, is we work with relevant authorities, of course, by all legal requirements in establishing the service, and also as well as working with all medical practitioners in establishing this. We are actually on the initial stages. We are doing those steps, and we are working with all doctors. And it just started, and this show we just started maybe bringing this conversation, and it's going to be more of this coming in the few maybe months and as we move forward. Yeah, basically. So I want maybe to move to the end of this session. So I want to say it has been really insightful session. So I want to give you guys, everyone, to give your parting shots. I'm sorry, many people, this is the time they are joining, but unfortunately, because of time, we actually have to wind it up. But we'll arrange another one, and then we can keep on having this conversation, as well as actually supporting medical practitioners. All right, so I will start with, let me start
with me, so that if I have a question, whoever is finishing will answer, because I have something I want Kenta, specifically Kenta, to respond. Okay. And also something specifically for Mboya.
Okay, you can ask. Yeah, sure. Just ask.
Yeah, so Kenta, what is the one specific thing you are addressing with your system so that we can buy it, or we can tell you to go and modify it and return it to us? So what is that one major thing you are addressing? So answer that when you are giving us your final remarks.
Okay.
Dr. Eddy, now I will not ask you many questions because of time as well. But I looked at your profile as one of the panelists, And I think I was told you are in charge of critical care. That's the part that I got interested in most. Now, what institutes an ICU? So that we know here that we don't have enough ICUs in the country. Some parts of this country, in fact, some counties don't have an ICU. What constitutes of an ICU and intensive care for a patient? And if you are to propose for the public to understand, what do you want us to know about ICU, so that if you would raise funds or to push our government, we do it from a point of knowledge to have this critical care? Lastly, on the same, how is it useful to have an ICU in a situation like this of COVID-19? And if we didn't have it, and if we had it, what will be the main difference? That's my parting thoughts.
Thank you very much. Alphonse, I want to bring Wekesa. Wekesa, give you a parting shot. He's also a regular person in terms of giving perspective. Wekesa, maybe you can make it brief.
I just even have a brief question, and this one goes to Dr. Wanjiku. I want to ask, how does FGM affect maternal healthcare in terms of mortality rate and everything to do with that?
All right, thank you, Sheila.
Thank you, Sheila.
All right. So now I'll start with Dr. Eddy. Dr. Eddy, you can give your parting shot.
Okay, now thank you so much. So maybe to respond to Alphonse's question, what institutes an ICU? So generally, an ICU is an intensive care unit. Basically, that's a specialized ward for taking care of critical conditions or acute patients or patients who need specialized interventions. So for an ICU, basically a patient who needs an ICU is we support systems which are probably impaired. That is, could be respiratory system, the cardiovascular system, that is the heart, the renal system, probably a patient who is in renal failure or has metabolic derangements, or the brain, patient who's had an injury or a post brain surgery patient whose level of consciousness is low and needs support. So an ICU is this specialized ward where you offer support to these patients. So basically the things you need in ICU, there are the machines which you need in ICU. If you leave the ventilator out, which for the common man knows as the life support machine, we have machines for administering drugs. We have machines for administering oxygen. So there are multiple things in ICU. We have multiple drugs we need in ICU. Then we also have the personnel trained specifically for ICU. So doctors, which I'm currently training in critical care. We have the nurses who are trained in critical care handling ICU. We have the physiotherapists. We have then the general supportive staff, the laboratory and everything. Then now we have specialized doctors like Kina Dr. O.Yonga, who come in to offer support when some of these patients' condition end up needing like things like sepsis. They always come in handy in helping us manage some of these patients. So ICU basically is a specialized unit. It's quite labor intensive, and also setting up one needs a lot of finance. That's why Kenya is still lagging behind in having some of these ICUs ready. Right. So generally, apart from that, I'm grateful for having been given this opportunity, and I think I've also learned a couple of stuff, and hopefully when there's another session and time allows, I'll be glad to be part of it. Thank you.
Thank you very much, Dr. Mboya. So I want to go to Dr. Wanjiku. Dr. Wanjiku, you can give your final perspective. Dr. Wanjiku?
I think I would like to first start with answering Wekesa's question. I think he asked the association between FGM and maternal health outcomes. I think that was the question. Yeah. Is he watching? Is he with us, or he left us?
is watching.
Okay, all right. I hope that's a question that I'm answering. So so first of all, FGM is female, genital mutilation, and it is graded. There's grade 1, grade 2, and grade 3. And depending on the grade, of course, the most severe is a grade 3. We actually have complications associated with FGM. Especially, we actually get most of the women having to go for a cesarean section. That's number one. And if they happen to do a spontaneous vaginal delivery, and so they would actually get postpartum hemorrhage, or they could they would need to get an episiotomy. And if they don't get an episiotomy, they would actually get a perineal tear. So in terms of the outcome, the maternal outcome, so those are the complications that we might get. So and also, if perhaps they have an SVD, a spontaneous vaginal delivery, then that would, especially for the infant, sometimes we get asphyxia, birth asphyxia, because perhaps they get prolonged labor. So by the time the baby is coming out, the baby is tired. So those are some of the complications, of FGM and maternal health and the outcome, the maternal fetal outcome. And then just a closing remark is thank you very much for having us tonight. It was amazing, just to talk about coronavirus, and especially in the area of obstetrics and gynecology. So any woman who's watching this, or any husband who has a wife who is expectant, a mother, a sister, anyone, please seek help. Coronavirus has not stopped reggae for obstetrics and gynecology. In fact, we are really working. If I turn back the time, I think babies that are delivering now were actually conceived in May, June last year. So I think it was a bit cold. Yeah, so we're having a lot of patients who are coming in for delivery. So I just want to just reiterate that, remember the danger signs, they are on your purple booklet. Yeah, if you have a headache, if you vomit at any stage of your pregnancy, if your water breaks before time, if you start feeling pain on your lower abdomen and to your back, if you get excess bleeding, vaginal bleeding, and if you just feel generally feeling unwell, you are welcome to come to the hospital day or night. Obstetricians are doctors who work 24 hours round the clock. So there is no, there's no excuse for not coming to the hospital because of coronavirus. No. Yeah, so yeah, we must deliver babies and we must keep conceiving. Obstetrics is the only medicine that keeps going, yeah, for procreation and life. So this is a message to every woman who's watching this, every man who has a woman in their life watching this, that obstetrics and gynecology, we are continuing, we are running as usual. We have our measures in place, we have our PPEs, we have our masks, so we are ready for you. And as I said earlier, we have the Wheels for Life initiative that was started by my colleague, Dr. Jemima Karaoke. Just call the toll-free number 1196. And you will be able to be picked from your home to your hospital of choice during the curfew hours. Lastly, I'd want to also speak a bit about mental health in this season. I think right now, today is day 65 since we started this coronavirus in Kenya. And the president has just issued an extension of the curfew from 7 p.m. to 5 a.m. and also an extension of the barricades, and the cessation of movement in and out of the 5 hotspot counties, that is Nairobi and its metropolitan, Kwale, Mombasa, Mandera, Kilifi. So I would want to tell anybody watching this, man or woman, child, parent, please talk to people. There is Zoom, there's WhatsApp, there's Facebook. Take your phone, call somebody, just say, hi, how are you? I want to talk, Keep connected, because it can get draining, especially if you're an extrovert and you're used to the outside, you're used to going out for coffee, restaurant, you're used to these outside things, yeah? So just keep connected, call your friends and loved ones, and just know how they're doing. If you're having a hard day, call. And I think also the Kenya Psychiatric Association has formed something in terms of where to get help. So I think after this live stream, I could drop some things on the comment section on which numbers to call. So your mental health is very important at this time. Thank you so much for tuning in. It was such a pleasure to be the only female. I feel so good. And I want to give a shout out to my Watus, of course, my mom, and everybody else who's watching. I don't know if I can mention it by name: Victor Raul, Victor Mwangi, Watele, Sheila Cheng. You guys are just amazing. So thank you for watching, and have a lovely night. Bye-bye.
Amazing. Thank you. You have really done well being among all men panel. It was amazing. So I want to come to you, Dr. Yonga. You can also give your parting shots.
Yeah. First of all, I think I'm quite excited, and I'm very grateful for you guys to have me here. I think it's very rare for me on a Saturday night to be discussing some of these things. I think I would be busy watching movies right now, but I think I'm happy that I was able to literally give one or two thoughts on issues of technology. Maybe just my biggest parting shot would be, number one, COVID-19 is one infectious disease that may not go away anytime soon. So we really need to make sure that we completely stick to the directives that have been given, particularly on issues of hand washing, issues of respiratory hygiene. Those ones really, I think, if we ever get out of this, those things should really be ingrained in a lot of us. The second thing is that, number two, now that we are anxiously waiting for vaccine, I think I need to remind all our viewers that we have many other infectious diseases which are actually even more lethal than COVID-19, but we actually have vaccines for them and people are not taking. For example, the influenza vaccine, the pneumococcal vaccine, and this one I'm particular about some of the viewers who may be watching us and probably are living with a particular NCDs, be it diabetes, be it hypertension, be it patients who've had coronary heart disease and have had some form of interventional cardiology intervention, people who have chronic obstructive airway disease, what people commonly call COPD, people with asthma, some of my very many patients who are living with HIV. There are many vaccines that are out there, but the uptake has been very poor. And so as we continue, as we wait for the COVID-19 vaccine, which a lot of us are working very hard to see whether we can get a few trials going on them, it would be nice if you consulted your GP or your doctor to actually figure out what vaccines are required for your particular situation, particularly some of these categories of people that I've mentioned. And number two, since I also see travelers, I know after people have COVIDed for quite some time, people will want to escape away for holidays. Make sure you escape when you have actually gotten yourself up to date on vaccines. So if you're going into the Northern Hemisphere, that is Europe or the United States, make sure you're up to date on influenza vaccination. For people who are diabetic and hypertensive and all those other NCDs, make sure you're also vaccinated against the pneumococcal disease. This is information that I'm giving you free of charge. Otherwise, if you are to see me personally, that's a serious consultation you'll be paying. But please make sure that you're up to date on your vaccinations, even as you wait for the COVID-19 vaccine, and keep safe.
Oh, amazing. Thank you very much, Dr. It's always a pleasure having you. So I want to move to Kenta. Kenta, you can give your parting shot as well as you can actually say where we can find Mediscan.
Okay. First of all, thank you very much for participating, Dr. Wanjiku and Mboya and O.Yonga. Thank you very much for participating in this session. So we try to supporting to the doctors, the enhancing of the knowledge and the empowerment through the platform. So that platform opened freely for all of the medical professionals in Kenya and East Africa in the world. So please tell us to what do you want to know? What do you want to learn? What do you want to enhance to the skill through any way, Facebook, WhatsApp, anything okay to us. So we can try to develop that kind of the system to you guys. And also, I would like to aim to the beyond the border of the knowledge and the skills. So you live working in the Africa, but so we aim to try to the inform to the information from Japan, from the Australia, from the America, all of the place to you guys for treatment of the patient. So we really supporting to the you guys, your guys, and your the empowerment for the patient. So if you have any request, please tell us by any way. So, and also thank you very much for participating in all of the participants for this session. We really appreciate. So I would like to meet you in online or in physical, the both of the way. But so I really hope to finish this situation immediately, shortly. So see you on the physical field. Thank you very much.
Amazing. Thank you very much, Kenta, for you are doing well. Huh? Good. Thank you. So I want to say, when it comes to Mediscan is working with relevant specialists. Of course, I personally am looking for doctors or any specialist we can work with, and also relevant organizations. So I think I'm in this landscape, and I'm working on that. And I think so far the response has been good, and we actually advancing that. And the purpose is just to enhance, of course, skills among ourselves, working with KOL or working with specialists or even doctors, the youngest doctor, I think, like Dr. Wanjiku, and also the organization. I think they're amazing. So we want to do that. Huh? So going forward, we'll also be having maybe conversation like this, and also we'll be having different ways we want to support medical practitioners in the country. So I want to say thank you very much, everyone who joins this conversation tonight. We are going to pin Mediscan on the comment box. For anyone who wants to register, please do so. After COVID-19, we are going to work together, of course, enhancing and also supporting existing systems. Asante sana. Good night, Daktari Yonga, Daktari Mboya. I know you are at work right now, but you had to find some time.
Asante sana, everyone.
Thank you. Good night. All right. Good night.
Good night.
All right.